Hi, everybody. My name is Melissa Wiles. I'm a graduate student pursuing the LPC, and I'm in the Department of Counselor Education at Emporia State. I am doing my presentation on reactive attachment disorder, which is also commonly called RAD. RAD is a trauma or stressor related disorder. On my board, I'm starting at the top left and going each column left to right. So synopsis of reactive attachment disorder is where I am. It is a trauma and stressor related disorder. That means the disorder is diagnosed solely on the response to a stressful or traumatic event. The only risk factor is significant neglect. For a child to be diagnosed with RAD, they have to be between 9 months and 5 years. The reason they start with that 9 months is because although you can see some negative effects before 9 months, at 9 months they expect to see certain attachment patterns and behaviors with children. So it really needs to fall in that 9 month to 5 year period for them to show a lack of proper attachment to their caregiver, which is typically the parent or guardian. Diagnostic criteria, so the child has to be between 9 months and 5 years. You have to have ruled out autism. The child must have been exposed to neglect or insufficient adult nurturing by the primary caregivers. Or they could have had inconsistent caregivers, such as would be found in foster care, meaning they've moved around a lot, and their caregivers have continually changed, so they haven't been able to form proper attachments with one primary caregiver or a set of parents. Or they were reared in an institutional type setting, and they can still have their physical needs completely met, their diapers changed, fed, a proper bed, things like that. But generally that's a situation where the facility just doesn't have adequate staffing, and the caregivers are continually changing with shift changes and things like that, so they don't get the nurturing that they need. In fact, this is the reason I chose this topic. I worked for a long time in a middle school where I was a counselor, and we had a large population of families that adopted children from Russia. And I had one interesting family that had 3 girls that were adopted. And so I got to see the kind of the ebb and flow of reactive attachment disorder and how it affected the girls in their schooling endeavors, their interaction with adults, interaction with authority. And I was just really interested in it because I got very close with the family of one of the family that had 3 girls out of Russia, and they had so many struggles, and I was just really interested in it when I knew that could be a topic. So that's what led me to choose this topic, because I have a great interest in it. To continue on from that, the child is withdrawn and aloof with caregivers and doesn't seek out any comforting. The other thing with that is if they do get comforting, like let's say a parent that's not doing a good job with that, and a grandparent comes in that is very nurturing, they are not going to respond to that nurturing. You can appropriately nurture a child that has RAD, and it's going to take time and effort and patience to get through that. They don't just suddenly, come and react appropriately because a person is treating them appropriately with nurture. So that's worth mentioning. They don't seek it out, and they don't welcome it. They have a rather flat affect. They don't really respond to others, or they can respond like they're scared or upset. They could cry, they don't make good eye contact, things like that. As far as things that need to be ruled out, so on a differential diagnosis, of course, autism, ASD, Very few kids with autism have experienced the severe social neglect of a child with RAD. Another thing is, of the children that have been experienced to severe neglect, only about 1 in 10 will develop RAD. As I get farther in my presentation, you'll see that there's not a lot of research, so a lot more needs to be done, but I'll continue with the differential diagnosis. Children with autism, as we all know, have a lot of self-stimulating behaviors, and so can children with RAD, so that can be confusing to the clinician trying to diagnose. Children with autism have strict adherence to routines and rituals, and that would not be found in reactive attachment disorder. So that can be a differentiating factor. Both kids with autism and those with RAD can show a range of intellectual functioning, but typically the children with autism also have communication disorders, and a child with RAD would not have that type of communication disorder that we all know is prevalent in children with autism. Even though children with autism might not attach at their chronological age, they will attach at their developmental age, and they will respond to nurturing, where a child with RAD will not. Another thing to rule out is intellectual disabilities. Developmental delays can co-occur with RAD, but they are not the same as an intellectual disability. Again, kids with an intellectual disability will attach according to their developmental level, and children with RAD will not. Depressive disorders, another thing to rule out. Again, a common theme here, the kids with the depressive disorders will attach, and those with RAD will not. Co-occurring disorders can include anything that has to do with neglect. So it could be malnourishment, it could be dental problems, it could be depressive symptoms, language delays. They could also have cognitive delays, stereotypies. Those are the most common co-occurring disorders. If we go into the next section, which is the bottom left of my presentation, the current research findings. Unfortunately for RAD, there isn't a lot. And I'm not sure that I think this will improve over time, because the primary population we see this is, and that we see this in, that they could study more easily, is the children that are adopted typically from other countries. A lot of those countries no longer will adopt their children out to the United States, and so we don't have that group of people to study. So I don't know that I see this changing a lot. And I know I've already seen it in my years as a counselor, that those kids are growing up and we're not seeing those kids. My experience is my kids from Russia, we don't get those anymore. They don't adopt to the U.S. And I have a little cousin in our family that came in from Guatemala. She does not have RAD, but they no longer adopt to the United States as well. They've shut that down. So I think that some of those factors will impact the research. But the things that we do know that have a link to the treatment planning and outcomes are the outcome will depend largely on the quality of caregiving post-neglect. It takes a really patient person, a person that will keep trying and not get discouraged in working with the children. Early intervention does improve the prognosis greatly. If the intervention is delayed, possibly they can develop behavior disorders, and social functioning will likely be affected. The next section in the middle at the top is evidence-based treatments. Very little research is available. There are no evidence-based practices yet to be determined. We need to ensure the child has the sensitive caregiver that's willing to work with the child. They're responsive to the child so that the child knows that they're going to be nurtured when they need to be, and that attachment can start to develop. And so it does take a special person to work with these children. There are some treatments currently being tested with children with RAD. One is called the Attachment and Biobehavioral Catch-Up, otherwise known as ABC. In that, the caregiver and the child would have 10 sessions with a therapist, which it's pretty simple. They're trying to get the caregiver to nurture and support in order to change the child's behavior. There are others that have been used but are not specific to RAD that I have listed there. There's one called The Incredible Years, which is used generally for conduct disorders. There is also one called Behavior Management Training, or BMT. That's a parent training program. Parent training is a big part of this, obviously. And then there's Mindful Parenting Training, which is obviously a parent training program. A caution, there are a lot of treatments that are very controversial, dangerous, and potentially deadly that have been used. And I think it's because the parents and the caregivers reach a point of frustration and they don't know how to help these kids. And so they're open to anything. What do I do here? Rebirthing, holding, and any coercive treatments should be avoided. They have not been proven to work, and they have had children die as a result. All that takes is a Google search. It's pretty scary stuff. But I think the initial, the parents seeking out that help, maybe their heart is in the right place, but they've reached a dead end, and they need people in the mental health community to help them find treatments that are promising. The next section at the middle, at the bottom, short-term and long-term goals of treatment and counselor implementation. The short-term and long-term goals are to build that relationship between child and caregiver and get them the child back to a point where they respond to normal nurturing and can live a more normal life and can have trust in people. One thing to make sure that the parents are aware when a child, say, for instance, a child was brought in via adoption that had RAD as a diagnosis, when they start to get treatment, some of their other things like developmental delays might improve pretty rapidly because they're getting consistent, concentrated help. And that can be discouraging because the parent is working with the child on the RAD diagnosis and they don't seem to see a lot of improvement. So to remember to encourage caregivers working with these children that it takes time and not to compare the progress related to RAD to that of other disorders. The counselor can work to implement treatment goals by being an active part of the collaborative team. They need to be a model of appropriate behaviors, working between the parent and the child, or working with the parent and child. They need to show how to be supportive and empathic, but also develop boundaries, strong boundaries, because I can see in working with these children myself as a counselor that it could be easy when you do start to see something good, that you think everything's good and you start to reward these children. And I think you would have to work with the parents on boundaries because this is new territory for everybody. Other treatments that are often used are psychotherapy for the child, family therapy, parenting training, special education services. And of course, that's my area. I know that in my experience with these families, lots of problems at school. I was working with a middle school age group, so 7th and 8th grade, and had several families with adoptees from other countries over the years, and lots of frustration for the parents. The kids tended to get in a lot of trouble, and learning to work with them and have a relationship with the family is very important, and be an advocate for that child and also for that family, because very few people understand RAD, and they think that the child is just being oppositional, and that's not really the case. These children can be kind of hard to like, because my experience is they don't necessarily smile a lot. They don't make good eye contact. They can be very much contrary. So working with everybody to understand that that is normal behavior, and things will get better over time if they're consistent and patient. The parents can also benefit from psychotherapy and counseling. At the top right, barriers to treatment and medications. Barriers to treatment would just be basically the parent or caregiver that is not emotionally healthy themselves, so they can't, this is a lot of stress on parents and caregivers, and they have to be taking care of themselves. They have to be healthy themselves to be able to see this process through. It's a long process, and lots of frustration, and probably lots of hurt as well, trying to do something to better the life of this child, and they don't necessarily get a lot of thanks in return, at least early on. I think in the long term it would be very rewarding, but it is a delayed reward. Also, barrier to treatment. In most families, the caregiving primarily falls on the mother, especially when somebody adopts one of these children in. Somebody goes to work, and the mother often is the one that is dealing with the child day by day as after an adoption takes place, if that's the situation, and she has to be able to handle the stress of the situation. And then whoever the parent is at work is working, whether it's the father or the mother, or maybe they're both working and a grandparent is helping them, whatever. I don't see in a lot of what I've read that it being real practical that these children are successful in a daycare type setting. So I understand in reading lots of different things that usually somebody is home with this child. So that's why I reference the mother. But anyway, they have to be able to handle the stress of the situation, because it would be very difficult. There are no medications that are used to treat RAD. If the child had a co-occurring disorder, of course, they could be on medication, but that would be the reason. Multicultural considerations. There really aren't any significant multicultural considerations at this point. Everybody that is studied in the literature has been in cultures where attachment patterns are expected to be similar to what we expect them to be here in the United States. However, if you're working with a child from a culture that's completely different, you would want to make sure you've studied that and understand what attachment patterns would be expected there, and not make assumptions. So not make a diagnosis in a culture unfamiliar to you before you would do some studying. That would be the ethical thing to do. Key stakeholders who may need to be considered when evaluating for continuity of care and collaboration. That's in the middle section on the far right. Obviously, all the medical professionals in that team. In the school team, which might consist of the classroom teacher or teachers if they're middle school or high school and changing classes, and then if they're elementary, if they have specials teachers or do class switches, all the teachers would need to know what's going on, be involved if there is an IEP or a 504 plan, the school counselor or counselors. You could have people like psychologists. If there's a lot of behavior concern, you would need to have the administration. Everybody would need to know kind of what is going on and be a part of that team effort to help this child and to collaborate. The parent guardian, obviously. Social workers and school social workers as well. the court appointed special advocate, and the guardian ad litem. That's really the end of my presentation other than the sources, so feel free to shoot me any questions you have about it, and thanks for listening.